Hello and welcome to the fourth module of point-of-care ultrasound at Legacy Health. This is entitled Renal Ultrasound, the Kidney and the Bladder. I'm Dr. Gordon Johnson, the Medical Director of Point-of-Care Ultrasound at Legacy Health. Again, some of the graphics used in this presentation were used with permission from Dr. Neelam Soni in his book, Point-of-Care Ultrasound. So first we'll discuss the objectives of the talk. First of all, the indications, probe selection, and positioning of the patient to do renal and bladder ultrasound. Next, we'll talk about some of the basic renal anatomy. Next, we'll talk about the scanning techniques used in each the kidney and the bladder. And finally, we'll talk about the grades of hydronephrosis that you might encounter, and then how to calculate bladder volume and post-void residual. So some of the common indications for point-of-care ultrasound of the renal system in acute care medicine include, first of all, acute flank pain, looking for signs of obstruction. Number two is renal failure, where you can answer the question, is the kidney obstructed or not? Is there a small hyperechoic kidney indicating chronic kidney disease? Next is looking at abdominal free fluid and ascites, and then again looking for bladder volume and post-void residual for signs of obstruction of the bladder outlet. So to talk first off the probes that you can use, most commonly is the curvilinear or abdominal probe to look at the bladder and the kidneys. If this isn't available, certainly a phased array or cardiac probe works very well. So when positioning patients, you want to have them lie flat on the bed on their back, and then again have them raise their arms like they're, quote, lying on the beach sunning themselves. And next you want to use the scoop position here to look at the kidney, getting down to the retroperitoneum there, looking at the liver and the kidney in this view here, as you can see with the anatomical diagram to the right. Here you can see the cortex of the kidney, you can see the renal pelvis as depicted in this graph. Cortex. Sometimes you can see the pyramids as hypoechoic structures. I find this in typically very young, healthy, thin patients. You'll see. You can see the calyces if it's any signs of obstruction there, and the renal pelvis turns black with obstruction that we'll talk about in the future as well. So then looking at the left kidney, very similar view. Instead of below the liver, it's just below the spleen here. Here you can see the left kidney in view. And the technique of reaching over the patient, you're scanning from the right, and then just putting your knuckles down to the bed and a little bit up towards the head. So again, with positioning, the scoop position, knuckles to the bed, probe marker towards the head to find the kidneys. Typically, I suggest looking for the liver first and then sliding down, and on the other side, identify the spleen, and then again, slide down and fan down, and you'll typically find the kidney in these areas. So again, just to review the right kidney, here's the scoop position, probe marker up towards the patient's head. I put my knuckles down towards the bed. I find the liver, and then I just slide down towards the kidney. Now, oftentimes you'll find the rib is in the middle. You can see the shadow here, and here we're just rotating the rib away. So what we do is we just slide down slightly, get that rib off the center, and then just a slight counterclockwise twist to get in between the ribs and get those rib shadows out of the way. This is very helpful in renal ultrasound. You can also slide down even further and then shine the probe up a little bit, looking up towards the kidney underneath the ribs as well, and you can try different techniques there to get your best view of the kidney. Again, this is in the coronal plane. So we always talk about one view is no view. What looks like a tragic situation here of a mother eating your young is actually a sweet routine little procedure of her just transporting her young kitten probably back to the den. So always get two views to really understand what's going on. And in the spirit of that, we're going to take this coronal view and the longitudinal view actually of the kidney, and we're just going to rotate here to the short axis of the kidney 90 degrees. And then when you're looking at it, you want to make sure that the kidney is isoechoic with the liver. If you see a hyperechoic liver, it usually indicates fatty liver or possibly cirrhosis. If the kidney is hyperechoic, it's often small, and this is typical of chronic kidney disease. So here we have a very hyperechoic kidney, and it's small relative to the liver. Again, you can see another depiction here of a hyperechoic kidney with a small cyst in the upper pole of the kidney. Now we're going to move on to hydronephrosis and the various grades of hydronephrosis. Here is a graphic depiction of mild hydronephrosis. These two in the middle are more moderate, often described as the bear claw look that you can see with the fluid in the renal pelvis and calyces. And then severe hydronephrosis, you'll notice that there's actually even thinning of the cortex of the kidney. So again, just another graphic description here of different grades of hydronephrosis. And here's a scan of an actual patient with moderate obstruction. So you can see this has somewhat of that bear claw look to it. Here's some better examples of moderate obstruction. Also, the one in the top right is probably the clearest with that bear claw, and you can even see the dilated ureter going down towards the bladder. The one in the middle, unfortunately, has a rib shadow again, so we should have slid down a little bit and then turned the probe and got that rib shadow out of the way. But there is obviously some dark fluid here in the renal pelvis indicating that there's moderate obstruction. And then again, just to review, severe obstruction here, you can see very dilated renal pelvis, dilated calyces, and loss of the renal cortex around these areas. Here's another example of very severe, long-standing, high-grade obstruction. Probably a non-functioning kidney there. When you see mild hydronephrosis, you need to be careful that you're not mistaking just the normal renal veins. So we always take a color box and put on this and put it on low flow and see if there's venous flow within the renal veins there. Not present here, but here you can see some of the flow. So this isn't obstruction down here. Now these, you can see these hypoechoic little triangular structures here. And again, these are the pyramids and seen normally in healthy kidneys sometimes. Here's a patient that came in with flank pain and a fever, had a UA that was positive for pyuria, and has a moderate obstruction over on this right kidney. No obstruction on the left. She had a large renal stone in there obstructing the kidney and causing the pyelonephritis. Here's an example of some hypoechoic fluid in the lower pole of the kidney. Here's a very large collection of hypoechoic fluid, anechoic fluid actually, in the upper pole of the kidney. The kidney is down here. These are examples of renal cysts. This one here on the right is a very large renal cyst. It's almost replacing the kidney. Now again, when you run into these abnormalities, if you see this on a CAT scan or something else, it's really good to put your probe on it, and then you can compare and see what it actually looks. This is the actual CT of a patient. Then we went and put the probe on, and you can see the small renal cyst here in our view. And this will train your eyes to recognize these things. Here is a frozen picture of it, and it's measuring it out there of that left kidney. You may run into this occasionally in the kidney, this hyperechoic area here, and then shadowing behind it. That just indicates that there's an intrarenal stone present in that kidney. Hopefully you won't run into this in your patients. This is a large vascular abnormality in the lower pole of the kidney. This is actually a renal mass and was a renal tumor. Sometimes you'll run into a patient with renal failure that has this look to it like a bunch of grapes, and this is pretty typical of polycystic kidney disease. So just again to go over your interpretation of renal ultrasounds for point-of-care ultrasound, you're trying to answer these binary questions. First, is the liver and the kidney isoechoic? Next, is there any fluid in Morrison's pouch or the hepatorenal space here? Making sure you look at the tip, caudal tip of the liver here, the most sensitive place to find fluid. There's no evidence of any fluid there. Then the renal pelvis, make sure that it's all hyperechoic. Again, if there's hypoechoic areas, put color Doppler there to just see if there are renal veins, which is really common. But this is hyperechoic here, so there's no evidence of any obstruction. And then finally, you can measure the kidney to see if it's normal size. Normal being 9 to 12 centimeters in that view. Okay, on to the bladder. So first, you generally get the bladder in the transverse view. Probe marker again to the patient's right, and then you need to fan into the pelvis. Oftentimes I see beginners are scanning up here. You have to actually fan the probe down to look into the pelvis to see the bladder. And here we're fanning through the bladder. We're not using a curvilinear probe here, so we're missing that wide footprint that would be ideal, but we can see most all of the bladder here and just fanning through it. And then once you get that view, you could turn on to the sagittal with the probe marker facing the patient's head. And then what we want you to do at that point is just, again, rock down to make sure you get the full view of this. And then once you get a full view, to fan side to side to look at the whole bladder and see the true biggest diameter, especially if you're trying to calculate volume. Here you can see the prostate down in this area. So calculating bladder volume is really quick and easy, and you can rule out significant bladder outlet obstruction just right at the bedside. So again, the first thing you do is get the transverse view, and you just measure the height and the width of the bladder and record that. So we have basically 6 centimeters wide and 6 centimeters tall. And then next you switch to the sagittal plane and get the length of the bladder right in the middle of the bladder here. You're just taking basically the average because it's not a true cube, of course, here. So you're right here and we're getting 5 centimeters. So it's just a very simple formula from high school geometry of height times width times length. And then we correct for that because it's not a true cube by multiplying it by 0.75. Some people use 0.5 just to get an estimated volume. So here we have 6 times 6 times 5 times 0.75, and we get 135 milliliters in this bladder. So no significant, or I would say serious, bladder outlet obstruction here. So next, the Butterfly-IQ has a nice function where it automatically calculates the bladder volume, as do some of the bedside nurses' ultrasounds. But note on the bedside nurses, they have them that'll just pick up fluid, so you often get a false reading if the patient has ascites. They'll come to you and say the patient has greater than 500 cc's of urine in their bladder when it's just all intra-abdominal fluid. So here you can actually visualize the bladder and then just hit the command that says calculate automatic bladder volume, and you don't even have to fan the probe. It just sends the beam down in this measure, and this is actually the same bladder that we did immediately after, and we got 141 milliliters of fluid, so pretty accurate with the other calculation we had. And then next is just kind of a fun party trick with everybody that does POCUS knows this one. It doesn't have a lot of clinical significance really, but here you're just looking at the ureteral jets coming out of the bladder. So what you do here is you just put it on in a transverse view, put the color flow on in a low flow setting, and if you wait about a minute or two, you'll often see the ureteral jet come in from the side. Sometimes it looks like crossing swords there. Why it's not clinically relevant, I understand that you can still have significant renal obstruction and see ureteral jets, but again, it is kind of fun to do. Now, a couple other things you might run into is this. In the lower end of the bladder is this big, huge mass in a male. This is an enlarged prostate. Here's another example of one in this area. It often has this bilobe look to it. And this is just BPH. And then next, you might get a case like this where the nurse says the patient has bladder outlet obstruction. They put the Foley in. They're not producing urine. They're not sure what's wrong. So you can just come with your ultrasound and look, and you can see the Foley is here in place. It's within the bladder. This is just an obstructed bladder, and I've ran into that a few times when the patient has hematuria. So you just need to flush it or possibly replace the Foley. And that's the end. Thanks for completing this module. Make sure you complete the quiz following this.